Thank you for inviting me. So today's topic is chikungunya and post-chikungunya arthritis. Uh, so first of all, what is chikungunya virus? It's an alpha virus. It's basically a single-stranded RNA virus with a capsule made up of capsid protein, that is the C protein, and again it has spikes, which is made up of three proteins, E1, E2, and E3. It's in the group of arboviruses. That is, it infects human by mosquito bites. Aedes aegypti is the main vector which is responsible for this infection. And there is another vector called Aedes albopictus, which is now being found to spread chikungunya virus. So chikungunya virus, the main epidemic started in the Western Africa, which is called the West African strain in 1952. Then a strain which was spreading in East, Central, and South Africa was the second strain. From there, in 2004, 2005, the strain spread it to the Asian part, which is called the Asian strain, and a part of it, which is called an Indian origin lineage, got spreaded in the Indian Ocean area. And this has now slowly spreading to the Europe as well as the Central and the Southern America in 2013 and 2014. So it's a very slow growing pandemic, and it's typically in the tropical region where the vector, that is the Aedes aegypti, can survive, and it is spreading slowly over years. And we are being troubled from 2004 2005 till now, and somehow this year the chikungunya epidemic was the cases number of cases were quite high, which you all might have experienced more along with your rheumatologist colleagues. So what is the clinical course of this disease? So with any other virus infection, like any other virus infection, even chikungunya, 15% of infections are asymptomatic. The range varies. The rest of the patient have three categories of disease: an acute disease, a subacute disease, and a chronic disease. So the acute disease is typically characterized by symptoms of fever along with polyarthralgia or polyarthritis, which is seen in around 100% of patients. Along with this, this typical acute illness can have myalgia and headache. Rash typically in chikungunya occurs after few days of fever and polyarthritis, around 5 to 7 days after the onset of fever and polyarthritis, and it remains for 2 to 7 days. It's a maculopapular reddish rash which is pruritic and can be seen in localized area or generalized, and is frequently being confused by patient as well as doctors as drug reaction. And it's basically due to the viral infection this rash occurs. And because it occurs after the fever is almost subsiding, it is often confused with the drug reaction. Along with this, the symptoms of fatigue, which is common with most of the viruses, diarrhea, and inflammatory edema of feet or both hands can often be seen in cases of chikungunya acute illness. The illness is typically not so life-threatening, but severe cases can occur, and mortality is, although present, is very low, 0.2%. Admissions are also low, that is around 6%. And most of the admissions are of short duration in a median of 5 days. The ICU admissions mainly consist of elderly patients who have comorbidities like diabetes, thyroid, diabetes, hypertension, cardiac disease, or chronic kidney disease. And because the vector for dengue is also Aedes aegypti, frequently we see a combined infection of chikungunya as well as dengue, and such patients may go into a severe disease and can lead to death in such complicated patients up to 1/4. That is 25% of this ICU admission can die. The other form, sometimes after this acute illness, around 50% of patients can have a subacute disease which may last more than 3 weeks. up to 3 to 12 weeks, and very few patients go on to have a prolonged disease that is more than 12 weeks, that is 3 months. This is the pictorial presentation of whatever I have told you. That is, after an infection, there is an incubation period of 2 to 6 days, followed by a acute illness of a week, which is characterized by fever and polyarthralgia and rash, which starts late. And then there is an subacute phase where the polyarthritis and polyarthralgia continues, and it can continue for years together in chronic cases. Viremia is present during the first week of the illness. With the just before the onset of fever, the viremia starts, and RT-PCR test of in the blood would be positive during this period. But this RT-PCR test would become negative in 5 to 7 days, and the IgM serology, the IgM antibodies would start appearing, which will persist till the subacute phase, that is up to 3 months. Later on, the IgG antibody will predominate, and it can be present for years together. Diagnosis of chikungunya is easy and is basically clinical. A patient with a fever and acute onset of joint pains, particularly in an endemic area, or has traveled from an endemic area, gives a positive predictive value of 80%. So if you have a fever with acute onset polyarthritis in an endemic area where you know the chikungunya is prevalent here, then it is 80% clinical diagnosis. Where there is confusion, we can use the RT-PCR test, or if it is a delayed period after 7 to 10 days, we can use the IgM serology test to confirm the diagnosis. Dengue, as I told you, is an important differential, and whenever there is doubt, along with the lymphopenia, which is common with most viruses, if you see thrombocytopenia, dengue serology should also be done along with it to ensure that you are not facing a combined infection of chikungunya as well as dengue. The chronic cases are basically diagnosed based on history, a temporal history of a fever and polyarthritis few months back, followed by a persistent polyarthritis for months together. Waxing waning symptoms would give you a clue that probably you are facing the chronic polyarthritis, which is post chikungunya. ESR and CRP can be high during this phase of polyarthritis and would help you to suggest the diagnosis. Along with the longer persistence of IgM has often been seen in these cases and suggests that this patient may go into a case of a chronic arthritis. We as rheumatologists frequently see such cases of chronic arthritis starting post-viral infection when they persist for 2 to 3 months. That is the time that this patient get referred to us, and this is a very good article being published in Journal of Rheumatology, which is being funded by NIH, National Institute of Health. And this study saw that what happens to this patient after 3 years of the onset of illness. So they had a huge number of cases, around 500 confirmed cases. And what they could find that after 20 months, when they telephonically asked these patients, and few were personally interviewed, and they found that 1 in 4 patients continue to complain of joint or musculoskeletal pains after 20 months of the onset of chikungunya fever, while 1 in 8 patients continue to have symptoms. 1 in 8 patients continues to have symptoms even after 40 months of the onset of chikungunya fever. So it's a good amount of patients which can have a chronic musculoskeletal pains or chronic joint pains after months, after more than 3 years of follow-up of this patients. What sort of symptoms does this chronic disease have? So most of the patients complained that pain was the main complaint, pain and discomfort. They also had mobility problems, problems with self-care, problems with daily activities, and depression and anxiety due to this pain and disease. But pain and discomfort was the predominant one. And this pain was typical in having periods of relief and recurrences. The pain would decrease and increase itself. And very few patients had a constant, very constant high intensity pain was very few patients. So pain was waxing waning sort of pain. And more than arthritis, like what we see in rheumatoid arthritis, the swollen joints, chikungunya related polyarthritis is less frequent compared to polyarthralgia. That is, the pain is severe, and many times you would not get that sort of signs on examination. You would not get the swollen joints typically seen in RA cases. The pain was typically provoked by exercises, was provoked by another infection. With any other infection, bacterial infection would result into relapse of pain, and the pain was associated with early morning stiffness. Few didn't complain of the stiffness, and the pain was associated with inactivity stiffness. That is, after sitting for some time, the patient had difficulty in standing and would need to stretch for 2 to 5 minutes to start doing activities. What was the pain is typically symmetrical. That is, both sides are equally involved. Involves almost all four limbs. Large joints like shoulder, knees, hip, wrist, ankles are frequently involved, along with smaller joints, and in some cases, involvement of the vertebral column is also seen. So they have all these large joints involvement in typically symmetrical fashion, and even in the acute phase as well as the chronic phase. They can mimic rheumatoid arthritis clinically very closely, although we don't find a typical erosion seen in the rheumatoid arthritis cases is very less reported in cases of chronic chikungunya arthritis. But on examination, you may not be able to differentiate between rheumatoid arthritis or a post chikungunya arthritis. Sometimes because this disease also involves ligaments, capsules, enthesis, that is where the tendons and muscles attached to the bone, as well as the tenosynovium, which is surrounding the tendon. This soft tissue involvement makes this disease sometimes undifferentiable from spondyloarthropathies. Also, sometimes chikungunya, post chikungunya arthritis has a good amount of neuropathic pain. And because of this, you may not find the clinical features, and you may confuse this case with fibromyalgia, which on deeper evaluation by history would give you a clue that you are facing post chikungunya arthritis and it's not fibromyalgia. Immunopathogenesis of chronic symptoms, it's because immunology is as such complicated. So it's very complicated. Many cells are involved which produce chemokines, and this chemokines along with interferons result into adaptive immunity and inflammation. It also affects the bone. But the main thing to remember is the virus was never being isolated after few weeks of illness, means after 1 to 3 weeks. In chronic phase, most of the researchers are not able to isolate live virus from the joint. Whatever we researchers have got is some of the virus materials which can be found in monocytes or macrophages, or replicants. That is, the virus is replicating but not infecting. The infective DNA is not there. So such persistence of virus materials are probably responsible why few patients go into the chronic phase, although we could not identify or tell that which patient would go into the chronic disease. We have no clinical clue. No study could be able to tell us that this patient would go. But yes, elderly patients, the patients who are aged, are more likely to go into the chronic phase of chikungunya after an acute illness, and younger patients don't usually are not prolonging it to a chronic disease. So what is the management of chikungunya? So the like most of the virus infection, the acute phase is mainly managed by rest and good hydration. The patient has to be hydrated well and rest. If pain is controllable enough by paracetamol and opioids, particularly in the initial 2 to 3 days, where you might not be sure that whether you are facing chikungunya or dengue, then paracetamol as well as tramadol can help you. Once you are sure that you are not facing dengue, and the patient's symptoms are severe enough to warrant you for with NSAIDs, and the patient doesn't have a major contraindication like a congestive heart failure or a chronic disease, chronic kidney disease, then you can go with the use of NSAIDs. Naproxen is a good use which can be given up to 500 milligram twice daily. that is the maximum dose, but usually they perform well with 250 milligram twice daily. Prednisolone is being used where NSAIDs are contraindicated, and there the maximum dose of prednisolone use is not more than 10 milligram per day, that is 5 milligram twice a day, and you should try to stop it within 2 to 4 weeks. It should never be continued for more than 4 weeks for the treatment of chikungunya acute arthritis. As I told you that many cases of chikungunya also have a neuropathic pain component. So sometimes when indicated, addition of tryptomer or pregabalin or gabapentin can help you with controlling the pain. The subacute stage of pain is frequently subacute and chronic stages of pain is frequently managed with good amount of NSAIDs. And if NSAIDs are contraindicated or are not sufficient enough to control the inflammation, then you use instead of a non-steroidal anti-inflammatory drug, you try to use a steroidal anti-inflammatory drug to control the disease. We usually in my practice, because nowadays we have a good amount of DMARDs available, so we hardly require a regular use of prednisolone in these cases. Few patients who have a severe disease may require a 2 to 3 weeks of use of prednisolone to control the disease. The DMARDs, which are frequently being used in these cases and have evidence, are hydroxychloroquine. The dose of hydroxychloroquine is 5 milligram per kg per day. That is what we need to remember very well, that in rheumatology, the dose of hydroxychloroquine is very low, that is 5 milligram per kg per day. And the maximum dose is 400 milligram daily, and it should never be given more than 400 milligram per day. Methotrexate is a commonly used drug for rheumatoid arthritis, and sulfasalazine alone also. Very rarely we require a biologic therapy like an anti-TNF to control the disease. And here also sometimes we need addition of amitriptyline, pregabalin or gabapentin to control the disease. Vector control, that is the control of Aedes aegypti and albopit growth of Aedes in the house artificial waters, is what is being done by the government. Along with this, there is a vaccine which is a measles virus live attenuated vaccine, and in this vaccine what has been done, a recombinant DNA of chikungunya has been put, so that some amount of chikungunya protein is also produced. So this vaccine gives protection against both measles and chikungunya, and it has just completed phase 2, and there is a study in Lancet of this vaccine giving good amount of immunogenicity against both this measles and chikungunya virus. There is another vaccine which is virus-like particle vaccine, which is basically an inactivated viral proteins, which is being developed by Bharat Biotech as BBB87. There are difficulties this both vaccines are facing is in phase 3, because the chikungunya epidemics is unpredictable. They occur 1 year or they may not occur the next year, and that is causing difficulty in phase 3. They are finding out the strategies so that these vaccines can complete the phase 3. Now, during our practice of 4.5 years, we have seen 129 patients, which we have a good data about it. So we have 129 patients data, which we have diagnosed clinically as post-viral arthritis. Out of this, we got IgM chikungunya serology, because I get patients during the subacute phases, and we could find we required IgM chikungunya in 79 patients, or they could do, that is 61%. And out of them, 70% had a positive chikungunya serology. The median age of this patient is 47. So whatever data is available in literature gives the age around 50-54. So we had a 47 years of median age, although patients were ranging from 17 to 75 years. And females are the predominantly involved, 80%. And this has been reported in other literature also, that 80% of cases are of females and 20% are males. 69% of patients presented to us in the post-monsoon period from July to December months. And the data is ongoing, and we are in the process to analyze and publish the data. So the take-home message with chikungunya is, so it's an acute chikungunya is basically a very easy clinical diagnosis wherever the doctors are seeing the cases left, right in the endemic areas, they can diagnose very easily, like we diagnose malaria. RT-PCR is sometimes required and sometimes not required. Staging needs to be and elderly patients with comorbidities particularly require closer watch. They don't If you are seeing the patient in acute phase, go for supportive care and analgesia. When you are seeing the patient in a subacute phase, go for anti-inflammatory, that is NSAIDs, and in cases where contraindicated steroids. And in chronic phases, rule out rheumatological diseases like rheumatoid arthritis, spondyloarthropathy, and there we use methotrexate, sulfasalazine, and other medicines. Prevention with vaccine and vector control is going on. Thank you.